Good afternoon. We'll be getting started shortly. I see people are still connecting to the webinar. We'll begin, and hopefully the rest can join as well. Good afternoon. My name is Lisa Oskwe. I'm a Senior Program Manager at PCMCH. Thank you all for joining us in our PCMCH webinar series for the Pediatric Diabetes Network and the Ontario Pediatric Bariatric Network. Before we begin, please note that towards the end of the webinar, we will have some dedicated time for Q&A. So feel free to type in your questions at any time in the Q&A box located at the bottom of your screen. And we will get to as many as possible at the end of the talk. With that said, it is my privilege to introduce you to Dr. Constantine Samaan, who's going to talk to us about traditional knowledge-based lifestyle interventions in the prevention of obesity and type 2 diabetes in Indigenous children in Canada. Dr. Samaan is Associate Professor in the Department of Pediatrics at McMaster University and a staff physician in the Division of Pediatric Endocrinology at McMaster Children's Hospital, Hamilton Health Sciences. Dr. Samaan is also an associate member in the Department of Health Research Methods, Evidence and Impact, and the Director of Research at the Michael de Groote School of Medicine at McMaster University. Dr. Samaan completed his training in pediatric endocrinology at the Hospital for Sick Children in Toronto, and pursued a research training as an international research scholar at St. Jude Children's Research Hospital in Memphis and at the University of Toronto. Dr. Samaan's program of research focuses on defining the determinants of obesity and type 2 diabetes in the pediatric populations and the development of interventions to treat and prevent these conditions. So, I'd like to give a very warm welcome to Dr. Samaan and pass it over to him to begin his talk. Welcome, Dr. Samaan.
Great, thanks very much, Lisa, and thank you very much, everyone, for being here today. I want to thank again the organizers for inviting me to share some of the work that we have done over the past few years in the area of obesity and type 2 diabetes. Today, we're going to be looking at some of the work that we have completed at this point, looking at the traditional knowledge-based interventions that are available to prevent obesity and type 2 diabetes. And we're going to look at the current evidence, and we're going to think a little bit about charting the course for the next set of interventions that are necessary. I live and work in Hamilton, and I would like to start the talk by giving my land acknowledgement, and that Hamilton sits on the traditional territory of the Mississauga, Haudenosaunee, and Anishinaabe, and within the lands protected by the Dish with One Spoon Wampum Agreement. Hamilton Health Sciences and McMaster University are sitting on these lands, and Hamilton Health Sciences is a privilege to provide care on the land that Indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous peoples as keepers of this land. And it's my privilege today to be here to speak with this group. So my objectives are to review type 2 diabetes, selected morbidities. And again, this is work that we have done over the past several years, and it's all published. We're going to review Indigenous interventions to prevent obesity and type 2 diabetes, and we're going to look at the systematic review methods that we have used to do this work. And we're going to review some select findings of this review. For those who are not familiar with the methods, I'm going to be spending a little bit of time just explaining the rigors of these methods and how we are reaching the conclusions that we have reached, because I think the method is important to firm up those conclusions. I do not have any conflicts of interests to declare. And the McMaster Children's Hospital Type 2 Diabetes program was established in 2012. And we're celebrating this year our 10th anniversary. it has been a tremendous journey for us, and we've had the privilege of taking care of many children from our indigenous communities who live around us. And we have truly come to appreciate the complexity of type 2 diabetes in children over that time period. And I just want to set the context here of the scale of the challenge we are facing with type 2 diabetes in children. This study that is almost a decade old now is reporting on the incidence of type 2 diabetes in the world. And as we can see, there are not really many countries that are represented in this data set. And I've labeled here in the blue arrows the Canadian data. And now keep in mind, this data is 20 to 30 years old at this point. And at the time, we had some of the highest rates of type 2 diabetes in the world. And that, of course, is really relevant to how we structure and set up our services to take care of children. These studies, as you can see, are predominantly coming from indigenous communities across the country. And they just highlight the scale of the challenge we are facing and the burden on communities with type 2 diabetes. And we can ask the question as well, why would type 2 diabetes be increased in indigenous communities? Up to 50% of newly diagnosed cases every year in Canada come from indigenous youth. And it's a complex question, and there's a legacy that is related to history and the history of colonial rules and how the communities had to deal with a system that has resulted in economic disadvantage, poverty. And it's important to know that over time, that system, of course, evolved from initial interactions into a level of assimilation and then towards cultural genocide, as was highlighted in the Truth and Reconciliation Commission report. And there were several areas that indigenous peoples were disadvantaged in. One of the things that I'm showing here on this slide are some of the changes that happened to lifestyle for indigenous peoples in Canada. And the 5 white gifts, and this is a term that is based on some of the rations that were provided to communities in the 40s, involved the introduction of a new set of dietary items that were not necessarily part of the traditional diet for indigenous communities. And that change, of course, in diet has changed the environment and changed the way people respond in terms of health outcomes. And that's an important issue that, of course, is related to the availability of the traditional food sources, their affordability, accessibility, and this dietary change has been quite significant, certainly in terms of its health impact on the indigenous people. The other issue is related to physical activity, and because of the way the lands have been allocated and changed, I can share, for example, in our area, the land that is available to indigenous communities over time actually has become smaller. And so things like physical activity or indeed a traditional activities such as hunting become really quite challenging to pursue. So the significant lifestyle changes that have happened over time has certainly contributed to the challenges with diabetes, and that includes type 2 diabetes in children. This is work that we have contributed to that happened with colleagues across the country, and in it we show the health inequity and the socioeconomic disadvantage for type 2 diabetes in children, and we compare that to type 1 diabetes, and we can see that in dark gray here is type 2 diabetes, and in the lighter gray is type 1 diabetes. We have looked at several domains, but the domains I'd like to highlight in this talk are really related to residential instability. We can see that type 2 diabetes in children, and most of these children are from the indigenous community, residential instability was higher than what it is in type 1 diabetes. The economic dependency was scoring, again, in the higher quartiles for type 2 diabetes, indicating economic disadvantage. And then situational vulnerability was also quite high in type 2 diabetes when we compare it to type 1 diabetes. And this again speaks to socioeconomic factors that might contribute to the development and sustainability of type 2 diabetes at the current rates that we are seeing in Indigenous children. This is work that we have done over the past 3 to 4 years that has looked at the comorbidities of pediatric type 2 diabetes in children. And this is work that was done by a student under my supervision. Milena is a very talented student that has done this work. And in a series of systematic reviews that are continuing to be published, this work is published or in a press, we looked at the prevalence of comorbidities related to pediatric type 2 diabetes. And when we look at the rates of obesity in children who have type 2 diabetes, about 75% of kids are overweight or obese. The risk of comorbidities such as hypertension and proteinuria affect about 1 in 4 to 1 in 5 children. The risk of polycystic ovaries in girls is around 20%. And the risk of diabetic retinopathy is around close to 7%. But that risk actually rises exponentially after 5 years of diagnosis. And this paper is coming out soon. It has been accepted for publication. So type 2 diabetes in children is a serious multi-comorbidity disease that is quite a challenge when it presents, because kids actually present with these comorbidities simultaneously. And this is quite significant because these kids will have to live with these comorbidities longer than adults who live with type 2 diabetes, because typically adult type 2 diabetes develops in the 4th or 5th decades of life, while kids are developing this disease in their teenage years. When we look at the prevalence of obesity across different ethnic groups, we can see that Indigenous kids, again, up to close to 80% of them have obesity when they have type 2 diabetes, which is quite a significant factor because that's a driver of potential cardiometabolic risk as kids grow older. And we also know that type 2 diabetes is a disease that fails a treatment quite regularly. And I'm showing here a slide from the Today study in which comparisons were made between metformin and rosiglitazone and metformin and lifestyle intervention. And this was a study that was a randomized controlled trial that included 700 children who were treated for 4 years and then followed up for an extra year after that. So the data that we see here is a 5-year data set. And what we can see here is that the kids who are treated, regardless of the treatment modality, do fail treatment at around 5 years, and actually a lot sooner. The failure of treatment was defined as the need for insulin therapy. And so over the course of a 5-year period, we can see that the treatment failure rates actually are high. And we can also see that these treatments didn't necessarily offer the control that you had expected or hoped for in the kids with type 2 diabetes. And we can see also that metformin alone or metformin and lifestyle intervention were actually close to each other and similar in terms of their failure rate. So this is a disease that is not only severe, but it's actually difficult to treat. And it's only recently that we started to see treatment modalities that are available to adults that are more available now to kids. And so there's hope that we have more treatment options as we move forward with treatment of this population. When we look at the data for Indigenous children for hypertension, we can see again that 1 in 4 kids have high blood pressure. And when we compare that to Caucasian kids, we can see it's around 20%. So there's a higher rate of hypertension in Indigenous kids when we compare them to white kids. And when we look at the albuminuria, again, we do see that about 1 in 4 kids have protein in the urine, and that's almost double the rate of Caucasian kids. when we looked at polycystic ovary in girls from indigenous and white backgrounds, there wasn't really a lot of data available, but what we can see is that about 1 in 4 girls had polycystic ovaries compared to about 1 in 6 girls who are white. So the risk of comorbidities actually is higher in indigenous children. So one of the things we were very interested in is really looking at the concept of prevention. So trying to delay or avoid the development of an end outcome like obesity and type 2 diabetes in indigenous children was really the main question that we pursued in this systematic review work that we have done. This initial work, the protocol for which was published, and it was done by a very talented student, Rebecca Crawford, who spent the summer with us through a scholarship for indigenous students who spent time at McMaster over the summer months. And she developed this protocol within our research group, and then another student took over the project afterwards. But we were very interested in the idea of prevention. And one of the things, of course, that we took on was the prevention of obesity as a way to prevent type 2 diabetes. Of course, this is a limited scope because we actually do not understand fully the mechanisms that are involved in the development of type 2 diabetes. We know that obesity is one of the major drivers, but the true mechanisms that drive the development of type 2 diabetes are not really fully understood. However, preventing obesity will go a long way in preventing type 2 diabetes. So we wanted to focus on this concept. We also wanted to focus on the concept of a traditional knowledge and the indigenous ways of knowing. Traditional knowledge and indigenous way of knowing is a system of knowledge that is based on the indigenous civilization take on health and well-being that has developed over thousands of years on this land. The indigenous way of looking at health is holistic, and it involves a complementary concept of the mind, body, spirit, and emotional well-being. And that holistic approach to health is really critical to consider when we're trying to prevent chronic diseases such as obesity and type 2 diabetes in indigenous children. So we wanted to understand in a little bit more detail what is currently known and what's currently available and has been used to implement interventions to try and prevent obesity and type 2 diabetes. And prevention was defined as the inclusion of populations that live with overweight or obesity, but with a stabilization or reduction in the BMI-based measures, or those who are obese but actually had a drop in BMI-based measures to the overweight or to the non-obese range. So it focused on a spectrum of BMI-based measures to try and see whether prevention could actually stabilize or reduce the BMI-based measures from the published evidence so far. So the main purpose was to assess the impact of indigenous knowledge-based lifestyle interventions on the prevention of obesity and type 2 diabetes, and we focused our efforts on indigenous children in Canada. And this work has recently been submitted for publication. Again, another student within our group, Maya, completed this project recently. And what we wanted to know were a series of outcomes. The main outcome we were interested in is to see whether any of these interventions have resulted in a change in BMI-based measures. But we also were interested in other outcomes, including a change in the amount of fat mass in the body. There is evidence that adiposity, or the fat mass in the body, is actually closely linked to cardiometabolic risk, and measuring it, while not easy compared to measuring a BMI-based measure, does offer additional information about body composition and its link to cardiometabolic outcomes. We also wanted to understand the changes in central adiposity, so things like waist circumference, waist to hip ratio, waist to height ratio, and skin fold thickness if available. We also wanted to understand if these interventions altered lifestyle for children and families, including nutrition and physical activity. And we also wanted to look at some biomarkers of change with the interventions, including glucose and lipid homeostasis. And what we wanted to know is, again, what papers should be included in this work. So we decided to look at studies of different designs. We included randomized controlled trials, quasi-experimental studies, and before and after study designs. We decided to include all Indigenous children and who are less than 18 years of age. And we included studies regardless of when they were published, whether they were done in community settings or urbanized settings, and we did not exclude language of reporting either. We only excluded the study if participants had developed type 2 diabetes, because our purpose was to study prevention. Those studies that reported on type 2 diabetes, these kids have developed the endpoint outcome here, so we did not include those studies. The way systematic reviews are done, they follow a specific format, and what it involves first is designing a search strategy to look at the different bibliographic softwares available. But it goes beyond that. We can look at something called the gray literature. So if there were any abstracts that were published, if there are any presentations and meetings that are available, and we looked at these databases from the start. So the data available to us span decades. And we assessed then the methodological quality of these papers by implementing, again, a set of very specific methods that are used in systematic reviews. One of them is called the risk of bias, to understand if there's any bias in the way the studies were conducted. And there are several tools that we have implemented for this purpose. And we also use something called the GRADE, which is a framework that is used to help us understand how confident are we in the evidence base that we use. And so that was also implemented in this systematic review. One of the other elements that usually are tested for is something called heterogeneity, meaning is how homogeneous is the evidence that we're looking at? Is there a lot of variation in the way these studies have been designed and implemented? Did they consider the same population? And that was, of course, an important factor to see that we can summarize this evidence or not. Can we include these studies together and make sense of them or not? We also looked at something called publication bias, in which you would say, if somebody has done a study, that study always get published. And if it isn't, then why wasn't it published? Was there something about the methods that were used or the outcomes that the investigators were not necessarily happy to report? And once we did all that assessment, we needed to make the decision whether we can do something called a meta-analysis, which is a summary of the evidence that needs to include studies of the same design, population, methods, analyses. And the studies were quite different by the end of the assessment process, that we actually could not do a meta-analysis because of the level of study heterogeneity that we encountered in the study. So we ended up doing just a systematic review, and we could not meta-analyze this data. So in terms of what we found, we could identify 10 studies that have used a participatory action-based model to engage communities. And that was actually an important finding, because engaging the communities is the heart of making sure that these interventions are relevant to the communities and to increase the participation and the buy-in from the communities. These interventions needed to be led with a vision of partnership in order for them to be implemented and be successful within the communities. And we find also different approaches. The majority of studies incorporated nutrition, physical activity, and some form of a psychological support or intervention that focused on areas like self-esteem, attitudes, and healthy relationships. 2 studies looked mostly at nutrition and physical activity, and 1 study focused on physical activity alone. So the approaches, again, were different, but the majority seemed to be aiming to implement a quite a diverse set of interventions. When we looked at the number of kids in the studies, there were 1,328 kids in those 10 studies who were in the intervention group, and then the control group had 382. None of the studies followed randomized controlled trial approach. The duration was quite variable as well. It ranged from 4 months to 4 years in 6 studies. And the other 4 studies were actually longitudinal programs that they reported annual data from programs that were ongoing in the communities. Now, I'm not going to go through the 10 studies, but I wanted to share some of the models that currently are in existence so that you can have an idea about, again, the diversity of these models that have been implemented so far. I thought we'll look at different models in different parts of the country. And the first one was the Sandy Lake Health and Diabetes Project in Ontario that was implemented in the First Nation community of Sandy Lake, Ontario. And the aim, again, was stated as the prevention of type 2 diabetes through obesity prevention. The program ran almost over, the reported data were from 98 to 99. And this was a school and community-based program. Now, I want to highlight here the significant amount of effort that has gone into the implementation of this program. And I think it's really important to acknowledge the work that was done here and the community's efforts that made this study possible. Because I think it was really important when we see this work to acknowledge that appreciation of the importance of this intervention. So from an intervention perspective, this was a healthy eating program, was implemented with healthy snacks. Schools banned unhealthy choices. Healthy recipe pamphlets were provided. Physical activity was emphasized with community walking trails, summer camps, and events. There was a diabetes curriculum for 3rd to 5th graders. Families were engaged with weekly community radio shows, video cooking clubs, and environmental and healthy eating school lunch programs. And there was also a cognitive therapy-based approaches with Indigenous learning approaches, for example, the use of storytelling and lesson planning and making sure that the education is culturally relevant. In this study, over that 1 year, the actual change in BMI was to the upper side. So the mean BMI and the percentage of body fat, in fact, increased with this intervention. But the intervention was associated with increase in dietary fiber intake for children and then improved knowledge about the healthy food choices and the dietary self-efficacy. And so we can see that this was a significant effort where the endpoints that we have chosen to assess the intervention seem not to change necessarily the trajectory of the body mass index and the body fat percentage in this case. However, there were lots of positive changes in the community that were certainly important to highlight. Another intervention was done in Quebec with the Kawanaki School Diabetes Prevention Project. And in this project, there were 2 elementary schools. This project was actually done in 2 groups from 94 and then in 98. And this was, again, a school and a community-based prevention program with healthy eating and physical activity focus with culturally relevant foods and activities. And then there was a school program that involved lessons given to kids with a curriculum about education about type 2 diabetes and healthy living. And there was a community arm where the newspapers and radio advertisements were used to report the results to the community with the promotional events. And there was quite an effort to enhance community ownership of the project. In this particular case, the BMI stabilized, it looks like, over time. So there was no reduction in body mass index over the intervention period. However, the physical activity component appears to have been enhanced with the intervention. There was no change in this particular case with the quality of the diet, but certainly the physical activity component appeared to improve with the intervention. Another intervention was the Earthbox Kids intervention from Alberta that was done in the First Nation communities in Alexandria, Alberta, a relatively small sample size, 76 kids. And this intervention implemented a garden educational project. There was a community-based, again, participatory research-based, and there was a 7-month gardening activity with a 4-month weekly snack program. And there was further emphasis on home consumption of vegetables and of fruits. And there was an improvement in this particular aspects for children. Children's choices of fruits and vegetables did increase. And however, the self-reported home consumption did not. So one of the limitations, of course, was small sample size and there was no control group. So the changes here were mostly in the preferences, but not actually in terms of making those changes in the home environment. And one final example was from BC, the Healthy Bodies program, and that was a program that had 118 kids in the intervention and 61 in the control group. And the program was a school-based program. 3 schools were supposed to start it, but 2 ended up participating. So the third school was used as a natural control. And it had 3 components, including physical activity, healthy nutrition, and healthy body image. This was a peer-led bodies program with 21 lessons and for fitness. There was also a fitness session that was added between bodies. The healthy eating was targeted through nutritious and non-nutritious food and beverages education. And there were also information sessions for senior students who then spent 30 minutes to teach the younger peers who were paired with them about healthy living. In this study, there was a change, a positive change on the reduction in body mass index Z score. So it was significant. And there was also, however, there was no change in the percent fat mass. From a physical activity point of view, certainly there appeared to be more or less similar between the intervention and the control group. And the reduced BMI Z score was something that I think is relevant and important in this particular case. The overall results suggested that the interventions were not necessarily effective in improving the secondary outcome of physical activity or a change in the use of unhealthy drinks such as sugar-sweetened beverages. But it did have a positive impact on the body mass Z score. So one of the things when we look at using the methods for the systematic review, it was important for us to know whether there was a randomized controlled trial approach and whether there was a blinding. So none of these studies were blinded. And again, there are different considerations here of how you can do this. But that changed then the risk of bias measurement of these studies. And for grade, which was the measure of our confidence in the overall level of evidence, the levels for both the body mass index Z score and central measures of adiposity was low. And so the quality of the evidence also were downgraded because of the fact that they were not randomized controlled trials. So in conclusion, the current evidence to evaluate these prevention programs was variable. And I think the non-randomization certainly is an important concept to consider here. And because of these limitations, we do feel that further research is still needed to clarify the most successful intervention. That doesn't mean that things cannot be done to make change. And all these interventions were designed with the idea of making change. It is mostly the way we capture this data so that we can think about generalizing it. However, we do also acknowledge that sometimes a local approach will be different based on the community preference. And we do, again, believe that community leadership and ownership of these trials are of paramount importance, so that these interventions are designed with the specific communities in mind so that they can be implemented with a positive outcome. Now, the local ownership and a strong community leadership and participation is, of course, crucial. And the use of Indigenous knowledge and practices must be central to this process of the design and the conduct and the evaluation of the data. And these partnerships and leadership of the Indigenous communities are absolutely crucial to design these interventions that are based on traditional knowledge and Indigenous ways of knowing. One of the things that the studies did not report on, and we could not find that evidence, is the evidence for interventions for Indigenous children living in urbanized settings, and whether there are efforts to use traditional knowledge to impact obesity and diabetes prevention. Those studies have not been done. And that's another group that we feel is quite important to address. Almost half of the Indigenous peoples of this country live in urbanized settings. So children's access to traditional based knowledge informed interventions is, of course, of critical importance. And one proposed, of course, roadmap for these interventions, they need to be owned, controlled, with data access and possession of the data by the Indigenous communities. That has been a fundamental principle in making sure that these interventions are relevant to the communities that we serve. And we certainly would feel that framing any intervention around these principles would be of paramount importance to ensure that the Indigenous communities could lead it and benefit from its outcomes. So thank you very much again for your attention, and I'm happy to take any questions at this point.
Thank you, Dr. Samaan. That was a great presentation. I just want to remind folks that if you do have questions, please use the Q&A box at the bottom of your screen to type in your question, and we will, I can read them out loud, and Dr. Samaan can address them. So we'll just give a few minutes for people to type in their questions. In the meantime, Dr. Samaan, congratulations on the 10-year anniversary of your program at McMaster Children's Hospital. Are you able to provide or share any feasible recommendations? We do have a lot of providers joining us today. Just any feasible recommendations from your experience and from your perspective for change that people could apply to their practice.
Yeah, thanks very much, Lisa. We certainly are very proud of the amount of effort that has gone into the program and what was achieved so far. I think it really depends. I mean, if people are considering establishing a program, I think it's really important to resource the programs with the appropriate resources. And the way we have adapted our program, it really embeds itself into our type 1 diabetes resources that are being shared to care for children with type 2 diabetes. But we also have developed specific expertise within the team in terms of lifestyle intervention and guidance, And more recently, again, we are using the more of the adult-based advanced pharmacotherapies that are available, and there's evidence for their efficacy and safety in the children and children with type 2 diabetes. And the program has evolved, I think, considerably over this time, because when we started, we had only metformin, and lifestyle intervention, sometimes was even the only thing you could offer. And then as time moved on, we started to realize the significant degree of comorbidity that these kids are facing. So then we engage other specialists to make sure that their other needs are met, because we realized actually we're not the only team members that these kids need. And from there, and I'd say in the past probably year or two, more advanced therapies like GLP-1 receptor agonists, for example, have been used in those kids with very good success. So it's been quite a journey in terms of understanding the scale of the disease and its impact on children. And the fact actually there weren't many, there remains again a limited set of interventions that we have for them. But I think this is changing, and I think this is actually very positive.
Great, thank you. So we have questions coming through. I'm going to start with the first one. How have the various communities involved responded to the results? And a follow-up question to that is, have they been discouraged by the lack of change in hard outcomes?
Yeah, that's a good question. The community in these particular studies that we have identified, the communities have been engaged actually from the very beginning. So the communities defined the research agenda, contributed to the design of the intervention, and the implementation, of course, as you saw from some of the way things were done, this had to be run by the community in order for it to actually be implemented. I don't think we have a lot of evaluation on, the kind of the response to the results. A lot of these interventions were reported mostly as, this is kind of the finding that we have. And the systematic review actually did not focus on trying to find the evidence for what was the community response. We focused on identifying the results. So we did not actually look for other evidence that is related to how the communities, dealt with those results. We're mostly interested in what were the results. And sorry, Lisa, what was the second question?
Have they been discouraged by the lack of change in hard data or hard outcomes? Sorry.
I think again we did not really look at the response or the reaction of the community to to the results. But I think again it's definitely a very important question to address for these sorts of interventions.
The next question is, have you considered looking at even earlier interventions, meaning interventions that start prenatally in infancy and or preschool age?
Yes, so that's a great question. So when we started the process of looking at the systematic review evidence, we actually did not exclude age as a defining factor. We did not look at pregnancy or in utero exposure. We looked mostly at kids who are essentially 0 to 18. So we did not find any evidence that was kind of dedicated, say, to below 5-year-olds. So a lot of these kids were kind of in primary school at that point. So we didn't find any evidence that was dedicated to the younger age groups, which is of course really important. And I think the question of definitely in utero exposure to diabetes and obesity is a crucial one in this population. But again, this wasn't really kind of the scope of what we were looking at. We're mostly interested in the prevention efforts postnatally.
Thank you. Can you clarify why the BMI was not going down for some communities when physical activity and diet interventions were taken? What might have been the reasons for this?
Yeah, that's a great question. It's really hard to know, because I think at the end of the day, an intervention is of a defined time period. the uptake, I would suspect, again, might be variable. And the larger the intervention, the more variation we're likely to see. This wasn't, again, a randomized trial where everything else is controlled for, and you're just having, a specific element of the intervention to evaluate. So there could be multiple factors that could have contributed to these outcomes that we're not sure why. So it's a good question. I think it's just hard to get at the answer for sure.
Our last question is there information about those children in the studies whose mothers had gestational diabetes?
That's a great question. The answer is actually no. Again, this was mostly, the nature of the intervention did not really collect that sort of data. So we did not actually have it in the published work.
Thank you. So this, I believe, brings us to the end of our webinar time for today. If there are no more questions, I would like to, on behalf of PCMCH, I'd like to thank Dr. Samaan for his insightful presentation today, and all of you for joining us today as well. As a reminder, once the webinar closes, we will have an evaluation survey will be sent to you. And we really appreciate your feedback on the webinar series and any topics that you would like to see presented in future webinars, to please do let us know. Thank you, everyone, and good afternoon.